Today to have Patrick Jeurissen with us from the Dutch Ministry of Health and from Rabud University in Nijmegen in the Netherlands. Patrick is very well versed in the process of contracting that is currently underway in the Dutch healthcare system, and we have a number of issues about contracting that could be interesting for thinking about implications in the Swedish health system. So the first question, Patrick, can you tell us something general about how contracting works in the Dutch health system and how health services have been affected by that process of contracting?
Okay, how it works is basically like this, Richard. An insurance company can purchase a health service, and it can also decide not to contract a certain health services, or it can have like quality requirements, or it can pay more or it can pay less. So it's very liberalized actually. So but up to 2012 it was liberalized but without risk, and now what we see is that it is liberalized, very liberalized. 70% of the prices are totally free, out of network, in networks totally free. Either do pay for performance or do capitation fees is totally free. But now there is risk for say 2 years, and now we say a very rapid involvement of all types of contracts. So we have now, for example, just in the Netherlands there live 16 million people, and only 4 million people have free access without any contractual limitations. That means 12 million people somehow will be steered to certain providers. So it's going very rapidly.
Is there any particular type or model of contracting that seems to be either more widespread or more popular than another? How is the process of contracting changing over time?
Okay, it all started when the whole contracting was based on price. Actually, a kind of DRG kind of contracting. But with scales in price. Now you see it's much more focused on quality of care, and as well it's much more focused on capitation fees. Basically the main type evolving is some kind of capitation fee with some kind of quality measures and some kind of output, financial output variables as well.
That's good.
Which is of course the new way for insurers or purchasers to manage risk.
Do you think that this has evolved because of unique social or institutional characteristics in the Netherlands? Is the way it has developed affected by the context in which it's taking place?
Yeah. Well, of course, it always was like a social insurance, a private insurance kind of system. So there always were some kind of contracts between the payers and the providers, but they are much more focused now. And there is actually one main thing, and that was the reform of the entire health system in 2006, the market reforms. Not so much from an institutional perspective, but that brought like a psychological distraction in the entire healthcare sector, because everybody was thinking, okay, we have a different healthcare system now, we should do something. And that brought some kind of legitimation to the purchasers, to the providers, and they started to rearrange their services.
They started to take the whole thing seriously.
Yeah, they started to take it seriously, although from an institutional perspective they didn't immediately had to do that. But psychologically it was a real change. And then in 2012 there was another major reform which actually made a market of something which wasn't really a market before.
Can you tell us a little bit about that reform?
The reform was basically that insurers be at risk on their. They really had an underwriting risk. They didn't really had any underwriting risk before.
No.
So they were.
So this is a big change in the Dutch system.
Yeah. So actually they had to accept all enrollees. There was community rating, and at the same time they be at risk. So the way for them to manage that risk is to do purchasing, selective contracting, and that's actually which really took off in 2012. And you see it very good in the pharmaceutical market. In the pharmaceutical market, we saw that in the current year, so 2013, there will be savings of up to 1 billion euros. In the Netherlands, which is basically completely the result of contracting, stiff purchasing, and was way less before.
So that's a big success.
That's a big success. Insurers are much more hesitant if you look at the hospital sector. I mean, they still feel, and they probably have to contract all the major clinics in the country. But they start to do is doing like volume thresholds for complex surgeries, which is something of a threat for the small hospitals because they do not always have enough patients, to guarantee the quality of care. And what is actually, from my perspective, a very exciting idea is the fact that for the first time we now also have physicians who, in name of the insurance company, so it's like the U.S. accountable care organizations. So the physicians in certain diseases set quality standards and take over or do the purchasing on behalf of the insurance company.
How have the hospitals in particular responded to this new environment, particularly the most recent change from 2012, in which the insurers now have more risk and therefore they are trying to steer quality and outcomes? Have the hospitals changed their way about producing services or their relationship with their doctors and nurses?
They are more or less forced to be very more open on quality of care, which was not like in Sweden where there's very well developed quality registries. We also have them, but they were not accessible.
Okay.
They were more or less forced to do that. Some hospitals, I mean, they basically do two things. Either way, they start to enter new markets. So they do more like outpatient care, all kinds of special services. But there are also hospitals who do more like who have more a defensive strategy, and the defensive strategy means that they merge and for example they negotiate a capitation fee. And that's actually not, because they really want a capitation fee. But if you have a capitation fee, it also means that new entrants have a difficult time. Because
so they protect their market.
In a way, it's actually an exciting mix of real innovation, new services, different logistics. New providers, and on the other hand, it's also a threat because for the last 10 years or so there was annual growth of 5-6% each year for the hospitals, real growth, and now there will be 1 or 2%. So now there is also a threat that they might actually lose market share, and then if you just make a broad arrangement with an insurance company, you can protect your your market share, basically.
But at the same time, from what you said, those hospitals are also reconfiguring their services.
Yeah, they do.
They're readjusting the areas that they expand into.
Yeah.
And I presume there are certain areas they are reducing some of their efforts as well.
Yeah.
So what you have in effect is an adjustment process taking place of the hospital to what the market provides at the same time that they are trying to protect as much of their existing market as they can. Both are happening at the same time.
Yeah, that's exactly, Richard, and it's actually, I think that is what really happens in this contracting and purchasing market. There is huge dynamics.
Huge dynamism.
Dynamism, yes, huge dynamism. Good, less good, and I'm very sure this wouldn't have happened if there was not first the psychological change of the market reform, and after that, when it went well for 5-6 years, the institutional reform of putting all the key players at risk. And what you see is everybody has to build a new strategy, and some things will not go good, will go wrong. But you also see much more innovations than, say, in the 2 decades, I would say, before this reform.
Can you give us an example of innovations on the provider side from the institutions?
For example, disease management organizations have come up, which were not there actually
before. This is for chronically ill.
Yeah, chronically ill, diabetes, but also heart failure and certain other diseases. We have 24/7 primary care centers coming up, who also do kind of acute surgery, which for people who otherwise would go to the emergency room in the hospital.
Minor surgery.
Yeah,
yes.
minor surgeries. Yeah. We have many hospitals are actually scaling down in inpatient care and in beds, and building small satellite centers.
That's extremely interesting. That's a change in their institutional infrastructure. It also means they have to change what doctors and nurses do.
Yeah. It means that the specialists are getting closer to where people are living. And for them it's also because, for example, you have a hospital and historically they have an area of, say, 10 miles from the hospital. And then they have the habit of building such a clinic at 9 miles, and the other hospital, which is 20 miles away,
feels the pain
and builds another center on the opposite. So what you do see is that there is all this movement, and then of course in pharmaceuticals, but also in pharmacists, it's totally rearranged the whole.
Now the pharmaceuticals are involved in longer term. Chains, for-profit chains have come into the Netherlands, I understand.
Well, they all, there are chains. Historically, they were like, you had a pharmacist and he had his own pharmacy, so he was actually as well for profit. But many of these pharmacies have been bought up by larger chains.
And then they contract with the insurers.
Exactly.
So that creates dynamism there too.
Exactly,
on the outpatient pharmacy side.
Yeah. But they had a real tough job because well, like I said before, I mean the pharmaceutical expenses, both for the medicine itself as the handling of the prescriptions, have been going down with 10-15%.
Which is extraordinary.
It basically means that you can be a for-profit pharmacist chain, but your profit margin has gone down significantly.
The profit margin may be the same, but the actual absolute amount will be less.
Yeah.
Looking at all this change that's already underway, and particularly this fascinating issue that it was triggered by a shift in the way of thinking that then unleashed these stages.
Yeah.
What do you see happening in the next period of years? Where will this process of contracting likely go?
Well, the big challenge really the big challenge is that policymakers, as well as stakeholders in healthcare, are able to pick up the best practices from all the changes which are currently happening. If they do that and help it and create more institutional efficiency, I think there is a good chance that value for money will keep on increasing in the Dutch healthcare system, and the system will be sustainable over the long-term care. We already have annual productivity growth of 3%, which is much higher than before, quite high. But on the other hand, and I think actually the current crisis is actually a blessing in disguise, because it more or less forces the government as well as the stakeholders to go that road and not be too hesitant in protecting the vested interest, which of course is the other side. If somehow we have a lot of change, and 10 years from now we have a lot of change, and then all go back to the same institutional configurations and the same vested interest parties, of course we do not have made that much progress.
Exactly.
But we hold it in our own hands, I would say.
That's important. You now have that possibility.
Yeah, I would say.
It sounds as though many of these structural changes and the contracting changes are linked to unique aspects of the Dutch environment. Do you think there are lessons for other countries that come out that can be generalized, even though so much of it is uniquely Dutch?
Of course. Some things, many things are uniquely Dutch. It's a market, but at the same time there is stiff corporatist governance
and social responsibilities.
And still there. So many things are still the same, and I think actually, that's actually a good thing, probably, because it seems to reinforce it. But for me, the main lesson is that everybody, meaning patients, providers, purchasers, other stakeholders, pharmaceutical companies even, they have to be putting at risk for value. And the thing is that if only one stakeholder is putting at risk,
is being put at risk,
it's not going to work. They need all to be putting at risk.
So you have to have a kind of a big gamble here.
What Donald Berwick calls, when he makes a comparison with climate change, only electrical cars will not do the job. Only reducing gas emissions or saving on oil will not do. You have to do it all.
It's a broad integrated policy.
Yeah. It's a broad integrated policy, and for example, if you have healthcare or services which is bad for your health, it should mean that it's not included in the benefit package, that there's no reimbursement scheme for it, that insurers will not contract it, that it's not legal by accountants, that patients will have to pay it by themselves.
Well, you're just describing a very large regulatory role for the state, but I think we have to leave that discussion for another time.
I didn't mention it that way, Richard.
But it sounds that way, and that's a very un-Dutch way to think of it.
Yeah, no, well, the thing is that all the parties need to have incentives to do the good things.
Themselves. So you build the incentives into the party's behavior,
and the way to do it is putting these people at risk.
So you use risk as a replacement for regulation.
Exactly. And then if something goes wrong, you start to intervene, but in that order.
Very interesting and very effective.
Yeah.
I must say, you have given us some real insight, not only into the Dutch health system, but into the dynamics of health systems generally. So thank you very much, Patrick.
Thank you, Richard.